Today's lecture is the future of AI in radiology, and we are very honored to have Dr. Jordan Perchik presenting for us. Dr. Perchik really is a true trailblazer at the intersection of artificial intelligence and radiology. As president and co-founder of Artificial Intelligence in Radiology Education, better known as AIRE, which is the world's largest free AI radiology course, Dr. Perchik has transformed training for over 500 radiology. Oh, looks like there's a little feedback. Okay, we're better now. For 500 radiology trainees across over 20 countries. At UAB, he's an assistant professor for abdominal imaging and informatics, and he leads pioneering advancements in digital health and clinical education. As a recognized leader in diversity, equity, inclusion, Dr. Perchik was honored with UAB's President's Diversity Champion Award for a significant contribution to patient advocacy. His groundbreaking work is truly shaping the future of AI in radiology, and we're thrilled to have him with us today. Please join me in welcoming Dr. Perchik.
I am really excited to be here today to talk about a topic that I have the opportunity, honor, pleasure to get to speak on pretty frequently, and that is the broad 10,000-foot view of what AI in radiology is, how we're addressing this in current day and what we are looking for in the near future of AI in radiology. So what I'm looking to do today, I want to start with looking at where we are. We're going to talk about, the different types of AI applications that you can see currently in clinical practice. We're going to talk about how we are approaching AI in our radiology training. And then we're going to close by looking ahead into, where we expect this field to be going in the near future. So just briefly, when we think about the purpose of AI, there are a lot of different applications that perform a lot of very, very different tools, and they can be involved not only in the interpretive process, but they're involved throughout the radiology exam lifecycle. So, the applications that tend to get the most press and get people most excited are the ones that are in image interpretation. Probably a lot of us have, I can maybe remember back in 2016, 2017, some of the headlines about X-ray interpretation applications that were able to detect pneumonia at a rate that was comparable, sometimes even better than the radiologist cohorts. And those caused a big panic. Everyone got very worried. And, there were extrapolations on that, oh, well, if the AI is able to detect pneumonia, then what else is it going to be able to do? Is the day of the radiologist numbered? And we just kind of hit the hype cycle and the snowballing of some of these very, very flashy headlines. And that's certainly not been the case for a number of reasons that we're going to get to. But I highlight that story also to point out that, AI in radiology is not just image interpretation. There are so many steps in the radiology exam lifecycle where AI can be implemented to make our practice better, safer, more efficient. And so, just overall, the different ways that AI can be implemented, it can increase our efficiency, it can improve our performance, our accuracy, we can implement it for patient safety tasks. This can augment our role. It can allow us to do new things that we've not been able to do, move beyond the capability of the human eye to be able to interpret images in a new way. It can provide quality and safety roles, serve as a second reader. It can help us in our decision process. But there's been a tremendous amount of growth with all of these different areas for AI to be implemented. There's been tremendous growth in the amount of research that we do in AI, and there's been a tremendous growth in the amount of AI applications that are achieving FDA clearance. So I give this talk relatively frequently, and I have to update the number of FDA applications every time I give this talk. So just the last time that I gave this, I had over 250 FDA cleared applications, and just in the about 6 months or so, it's jumped up to 300. So this is, it's been an exponential growth in the number of AI publications, translating into an exponential growth in FDA cleared applications. And this is one of the best resources that we have in radiology to stay on top of the AI marketplace. This is called AI, or it's the American College of Radiology AI Central Database. And this breaks down the total number of applications that are in different categories. So you can see we have applications across the body for a number of different focuses, number of different types. And I mean, there are hundreds of these. As of yesterday, it was 333, and there will probably be more by the end of the year. And so, you know, if you're
I
a
was born in
medical
Cuba.
student
I shouldn't be
entering,
allowed to vote on this.
I mean, I was born and didn't, and I just hated when it got cold and didn't.
Yeah, I'm okay with human.
as a reminder, if you can mute your Zooms, I'd greatly appreciate it. But you know, if we are in radiology, we're starting our residency, it's hard not to feel a little anxious about the looming AI menace. And you know, it's not unreasonable to start thinking, oh man, look at all these things that AI can do. How long do we really have in radiology before the AI machine takes over? And you know, as far as where we are, that really truly has not been the case. So the greatest or the trend that we've seen with clinical AI is that these applications are narrow and they are brittle. So a narrow AI application, when we say that something is narrow, we say that it's not a general application. There is no AI application that we can plug in a CT, chest, abdomen, pelvis, have it spit out a total report, a conclusion, follow-up recommendations. Or, you know, there's no AI that can perform the full role of the radiologist, you know, really by any stretch of the imagination. It's really quite the opposite. So going back to that example of the pneumonia application, so that application was able to do very well detecting pneumonia on X-ray, but that's it. Like it detects pneumonia on a chest X-ray. It does not detect pneumonia on a CT. It does not detect pneumonia on a MRI. It does not detect pneumothorax on CT. It does not detect pneumothorax on X-ray. So these are very narrow applications, and we have to treat them as such. You know, some of these other applications that they get trained, they do very well in the literature. There are problems with generalizability. So they do very well on their own training data set, but getting out into the real world where you have a wider variety in patient images, a wider variety in patient populations, they tend to degrade very quickly. And that's where we start thinking about algorithm bias as well. That, you know, we worry about these training populations that maybe in the training data set, you have entire populations that are not represented, and you go out into the real world, into general practice, and this algorithm is exposed to different patient populations and maybe exams from different scanners, and it doesn't do as well. And it may take time, and it may take multiple sentinel events and adverse events and bad outcomes to even detect that this bias is going on. And so with that, you know, we also have the evolving medical legal landscape where, you know, we really don't know exactly where, you know, where the liability is going to fall for some of these AI processes, that if the AI takes us down an incorrect route, there's a bad patient outcome. You know, we are ultimately responsible for the final read as the human radiologist. But, you know, where does that liability lie if we are being biased by an incorrect AI outcome? And then finally, we're getting some support and we're getting some guidance from the government. This is an executive order from last year on deployment of artificial intelligence. There's a specific caveat specifying human oversight for high risk, high stakes integrations like healthcare. There's been a similar law that's been passed in the last year in the European Union that has similar language requiring human oversight for AI in healthcare. So there is a recognition at the government level, the regulation level, that human oversight is important, and that we as human radiologists are needed to serve as the gatekeeper in the final read for these high stakes exams. So for those of you who are in the audience, who are medical students who are concerned about how AI is going to affect your practice, I do want you to recall that AI is going to be a tool. AI is a tool that we can use to support and augment our practice. So there's a lot of different applications that we have that we currently use AI to augment our practice. We have a kind of a sampler platter here of a couple of these applications, examples of these that are currently in clinical practice. So on the far left, we have a computer-aided detection tool, abbreviated to CAD, that is highlighting a breast cancer on a mammogram. We have an example of an application that highlights an intracranial hemorrhage and then is also integrated with the work list. It brings these positive studies up the work list for earlier interpretation and hopefully earlier treatment. In the top right, we have a computer-aided diagnosis application that's helping us diagnose a lesion that we see on ultrasound, another lesion that's detecting pulmonary emboli, so blood clots in the lungs. And then we have a 3D segmentation application that is providing a 3D volume rendering of a tumor that's in the brain. So like I said, there's over 300 FDA cleared radiology AI applications, and these are present across specialties and across modalities. The most commonly represented subspecialties are neuroradiology and cardiothoracic. And there's a couple of reasons for that, but mostly because those are the ones that have the large anonymized data sets that have traditionally been able to be used for algorithm training. Just lowers that barrier, makes it easier to develop algorithms for those subspecialties. Applications can broadly be divided into two categories by the FDA. So these are medical image management and processing systems, or MIMPs. And these are primarily related to image quality, image processing kind of applications. And then you have computer-aided detection applications. And these are related to assisting the radiologist in making their diagnosis. And there are three subtypes of these. So when we think about CAD, this can be further divided into computer-aided detection, computer-aided diagnosis, and computer-aided triage. So a detection tool is going to assist the radiologist in detecting a finding. A diagnosis or a computer-aided diagnosis is going to detect the finding and also provide an assisted diagnosis category. And then triage would be where you have work list interpretation, and it can bring these positive studies, especially those that have more emergent exam findings like hemorrhage or blood clots in the lungs with the pulmonary emboli. It brings those up the work list for more urgent interpretation. So when we are approaching an AI application in the radiology department, whether that is when we are considering purchasing an AI application or when we're thinking about how we're going to manage an application we already have in practice, we have to understand the type of application that we're dealing with. So we can think about, is this going to be something that's more related to image processing, or is this more related to diagnosis assistance? Alternatively, we can think, is this a interpretive or a non-interpretive process? Is this helping the radiologist with interpretation, or is this involved in something that is not really related to the interpretive process, maybe like image quality or scheduling or other processes in the AI radiology exam lifecycle? And when we understand the type of application that we're working with, it helps us also figure out what kind of mistakes we're going to need to look for, because algorithms that are in practice, just like any practicing human radiologist, are going to make mistakes. So being able to anticipate those mistakes helps us plan on how we're going to manage them when they occur. So I have a couple of examples of these AI mistakes here. So we have example images from this is an intracranial hemorrhage detecting algorithm that we have in practice. It's very commonly used. This is probably one of the more popular exams that's in use throughout the United States and internationally. But this is scrolling through a CT head without contrast. This is a very typical exam that we get, especially in the emergency department, where we're looking for intracranial hemorrhage, so bleeding inside the head. So blood inside the head is going to be bright. This is a pixel-based algorithm, so it's scrolling through and it's looking for these focal bright areas where they shouldn't be. In short, that's a very 10,000-foot view of how this application is working. But not everything that's bright inside the head can be blood, or not everything that's bright inside the head is blood. So we have a couple of, typical normal anatomy, anatomic variants that can be these focal bright spots. So we have right here, this the typical location for a choroid fissure cyst. And then we have another normal piece of anatomy here, which is part of the choroid plexus. But both of these were highlighted by the AI as highly concerning for intracranial hemorrhage. And then similarly, we have other pathologic processes that also, similarly, you scroll through, it's a focal bright spot. The AI thinks, all right, it's bright, it's inside the head. That must be blood. I'm going to flag this as positive, but that's not necessarily the case. So we have here a partially calcified aneurysm arising from the left ICA or the left intracranial artery. And then on the right, we have someone who's previously had a stroke and, they have progressive calcification of that area that's had this insult and just relative to the surrounding scarred brain tissue, it's brighter than the surrounding tissue, and then that is highlighted as concerning for bleed. Neither of these are acute intracranial hemorrhages, but they are pathologic processes that have tricked the AI application in this case. Similarly, we have a large meningioma. So again, this is a large bright area. The AI thinks that that is blood. And then on the right image, we have this hot spot here, but that's corresponding to a hyperdense vessel from someone who has a blood clot inside their intracranial vessels. So certainly they do have pathology going on, but it is not the pathology that the AI thinks it is. And then last example here, this is an example of contrast staining. So someone who has had a stroke before, they've received an exam with contrast, and that's just residual contrast in that part of the brain. The AI has a very difficult time. This is one of the very common false positives that we get, that this is just residual contrast hanging out in the brain that the AI thinks is acute hemorrhage, but is actually just a typical pathologic finding. Oh, and excuse me, I do have just a couple more here. So these are imaging artifacts, again, that are just fooling the AI, that we have a lot of motion here. The typical human being does not have two skulls inside of each other. This is from the patient moving around on the table, and just another very typical image that we can get from the ER department. But this fools the AI. It thinks that there's a hemorrhage back in this area, but this is just part of the skull. And then we have a metallic device here that's causing these linear streaks that again is fooling the AI into thinking there's an intracranial hemorrhage. So, by us understanding what the algorithm is, how it makes its decisions, we're able to more effectively triage those false positives and convince ourselves that this is not truly an intracranial hemorrhage, and we can let this go. And that's important because we don't want to falsely diagnose someone with an intracranial hemorrhage, get them down the wrong treatment path, potentially get them set up for neurosurgical evaluation that wasn't needed, potentially require an additional inpatient stay that isn't needed. So these things that we have in practice that are supposed to make us better, faster, safer, can sometimes make care worse if we don't know how to use them properly. And so that brings us to our AI, what we're doing for AI in radiology training. So AI in radiology training, unfortunately, is relatively rare. A survey in 2020 showed less than 3% of AI or of radiology programs had dedicated AI curricula. This is thankfully rising, but still less than half of residencies have any AI training. And that partially is because of just the limited expertise in AI that we have, at even large academic institutions. The large academic institutions that are able to, they have their own AI infrastructure. They have experts in every department that can integrate this type of education into their noon conferences. That's great, but that's really not realistic for everywhere in the country. So this is limited to these large, well-staffed institutions, but is pretty disparate even throughout the United States. And even for these programs that do have an existing curriculum, there's a wide variability in terms of what's taught. Are these going to be teaching? Are we going to be learning coding? Are we going to be doing this over the course of 4 years? Is it going to be a single week? A single week every year? Is it going to be 1 month for the entire training curriculum? It's we don't have a standardized AI curriculum or education milestones, so it makes it difficult to compare how effective these programs are across different programs. So there are resources for for our residents and for trainees at any level, practicing radiologists, to gain more of a familiarity with the fundamental concepts of AI. So these are free and paid options. So, for individuals who are looking for more experience with computer science, programming, dedicated machine learning courses, there are options through Coursera, Code Academy, edX. There are CME courses that are offered through some of our professional organizations. That includes the Radiological Society of North America has an AI certificate. National Imaging Informatics curriculum is offered through SIM. And then as our own internal bias, we host a free annual curriculum that's a 1-week fundamental concepts in AI course that we run every year, that is now one of the largest free AI education resources for radiologists. So there are options, but it's very important when we're thinking about these to think about what our learners are really looking to get away from this, or get from these courses. So for the vast majority of our trainees, these individuals need to have a general concept of how AI applications work, know how they can be deployed effectively, know how to manage them in practice. So we want these individuals to have a general overview of the practical applications. These people can focus on the basics. They want to focus on how they're going to affect daily workflow, and they need to know how to handle false positives and false negatives. Excuse me. At a higher level, you can have individuals who are aiming to be department leaders, or maybe AI liaisons within their practice or to the larger health system. And for these individuals, they need to be able to focus on algorithm training, how they are going to develop quality assurance practices for AI in practice. They need to know how to approach the AI marketplace, and they need to know how to deploy an algorithm in clinical practice. And then at a higher level, you have, an AI developer and clinical researcher. This is going to be the individual that needs to be an expert on the statistical methods, data preparation, and they need to have a more robust coding and computer science background. So that's not something that's required for everyone. The ability to code and a background in computer science is not a prerequisite for our course, and I don't believe should be a prerequisite for being able to use AI effectively in practice. I'm a firm believer that focusing on the basics, knowing how to use these tools in daily workflow, triage errors when they occur, triage and recognize errors when they occur, is sufficient for the vast majority of radiologists who are going to be using AI in practice. But across the board, knowing the ethical background for the use of AI in healthcare is going to be necessary at every level. So there are a few key concepts that we're going to highlight here. This could be an entire lecture in itself. But when we think about the ethical deployment of AI, we think about ensuring we want to ensure that there's adequate diversity in algorithm training. The phrase that we point to frequently is that biased data produces a biased result. And so, the algorithmic bias is something that, it can be very insidious. It's very hard to detect. And it requires really a lot of work on the front end to prevent rather than trying to detect it after deployment, because it can be very, very challenging. And in this case, algorithmic bias can not only perpetuate health disparities, but it can even deepen health disparities that already exist. So, with that, we want to ensure that some of these applications that are providing breakthroughs in care, that are providing earlier diagnoses of cancer and optimizing patient care for other severe diseases, we want to make sure that these are deployed equitably, that we're not introducing a new disparity of haves and have-nots in terms of access to these applications. We want to ensure patient privacy, where there are considerations for ownership of data when we're talking about training data for AI. And then there are, of course, concerns about AI, concerns and discussions about AI autonomy and medical legal liability for more autonomously functioning AI applications. So we're going to close by looking into the future a little bit for just a couple of exciting potential areas for AI deployment that we've talked about a few times in our course and with a few of our experts here at UAB and in the national course that we do every year. So I'm going to jump right into it because I think a few of these are neat. So when you get an exam, typically now, so if you're going to come to UAB in Birmingham, Alabama, and you wanted to get a CT scan, what you would do is you would come in, you would check into the radiology department, you'd get your exam, you'd go home. Even in a very efficiently operating radiology department, you probably would not have your exam interpreted until you were at least in the car or maybe at home, maybe even the next day if it's a particularly busy day. But it's not infrequent that we do these exams and we have emergent incidental findings. So we have blood clots, we have hernias, we have other issues that really need to be evaluated that need to be evaluated more urgently. So we think about in the future that we can have an individual come to one of our imaging centers, they get scanned, these images are sent off to a suite of AI applications that are screening for emergent findings. So, this is not providing an interpretation of the entire exam, but this is looking for intracranial hemorrhage, pulmonary embolus, blood clots, free air in the abdomen, things that would really need an emergent workup, maybe an admission to the hospital. And so after the patient gets scanned, these AI applications run in the background. They get a text alert on their phone, and they say that they've been cleared for discharge. And this is before the human radiologist would even be able to look at the exam because it's happening just so quickly in the background. So looking forward, we can also anticipate some element of automated report generation. So a lot of us have moved to structured templates similar to the one that we have on the right. So we break these down based on anatomic area. And so integrating some of the existing applications that we have with the structured report. So we have an application that detects a pulmonary embolus, so blood clot in the lung. So, it only takes, a couple of additional steps from some of the AI applications that we already have in place to take the finding from the image to integrate it into our report. And then at that point, I, as the human radiologist, could scroll through, look at the areas that have been described, either agree or disagree, and then move on to the next case. Now, this is a very exciting area that's going to be coming out sooner rather than later. This is a topic called opportunistic screening. When we get CTs of the body, there's a wealth of information that's present in all of these images that we're not using for our interpretation. So these things that are in the background that, it would take an exceptional amount of time to do 3D segmentations, to perform analyses on all of these different areas. This can be done, again, in the background automatically and provide objective measurements for things like subcutaneous versus visceral fat, bone density, liver volume, brain atrophy, aortic calcium, and so on and so on and so on. So if you can imagine someone coming into the ER for abdominal pain, they get a CT, and this is an example image on the left. I'm looking through, there's no abnormalities, the appendix looks fine, no gallstones. I might just dictate this as no acute abnormality and move on. But say we have the opportunistic screening application running in the background, and it segments out the patient's visceral fat to subcutaneous fat, and it says this patient's at risk for metabolic syndrome. They can segment out muscle density. They can measure the liver volume, which is something that's notoriously difficult to do in 2 dimensions as opposed to 3 dimensions. So all of this is essentially free information that's in a patient's CT that I'm not using for interpretation, but could be used to help guide their treatment in other areas. And then we have radiomics, which has colloquially boy, words are hard. So the colloquial way that this is referred to sometimes is the virtual biopsy. That this is a very advanced technique in deep learning that uses feature extraction and texture analysis of the image. And this can be used to determine a tumor type from radiology images. You know, it's also been shown that this can even guide treatment. It can suggest treatment regimens. It can provide prognostic value. This is just a quick example of what one of these applications can look like. The issue with these is that they have been mostly limited to the research space. There's been problems with generalizability. And also, this is something that's going beyond the human level that I can't provide a quality check with my simple human eyes to tell you exactly why this says this type of breast cancer is this type and would respond to this chemo regimen. So there's an issue of this black box reporting. And we don't have just applications in radiology. That's one of the things that I've been very impressed with this group, that you are providing a very comprehensive view and a very diverse view of how applications can be deployed in lots of different medical specialties, throughout the healthcare field. I sometimes have to convince other specialties that AI is not just limited to radiology or medical imaging. This is something that is going to be coming for every specialty, and is something that every specialty is going to need to understand and is going to need to know how to embrace and not only embrace but know how and when to be skeptical. So for pathology, that would be a pretty one compared to radiology. We have a lot of image processing. We have a lot of diagnoses, cardiology, medicine, oncology, surgery. All of these have had significant increases in research and publication in the past 20 years. So there's a lot of reason to be excited across the board. And I'm not going to dwell on that because I think that you all have a great resource already on your hands for learning about the different applications of AI and other subspecialties. So at least for radiology, we have started to carve out our role with this experience in AI that we can serve, as liaisons and leaders for how AI can be deployed clinically for other specialties. In the very similar way with telehealth, we've at this point had about 5, 6, 10-year long head start on a lot of the other specialties that are starting to integrate AI. And so I hope that, something that you all take away from this is that, you are not in this alone. AI deployment is a team sport, and you can look to your colleagues in radiology for experience and for guidance with bringing these into practice. So with that, I really appreciate the time to talk to you all today, and I will be very happy to take some questions.
Hello, can you hear me?
Yes.
Thank you so much for your awesome presentation today on AI. I have a question regarding training and validation of like deep learning models used for like AI segmentation. So I know that the accuracy is partly determined with a lot of these AI models by dissimilarity coefficients. And I was wondering, like, what dissimilarity coefficient is seen as a gold standard when training and validating models before using it in clinical practice, because I have yet to see a gold standard in dissimilarity coefficients.
Oh, what a good and very specific question. So I don't have I have a subjective, typically we don't want anything that's really below like a 0.9. So when we say dice coefficient scores, so that's comparing the overlap between what's something that's automatically segmented versus something that's segmented by a human user, and the human would be the gold standard. So if there's perfect overlap and it's a perfect segmentation, then that would give you a 100% overlap, but that would be a 1.0. If it's a 90% overlap, it's a 0.9, 80% is 0.8. I've seen plenty of publications that will talk about a 0.8. Above a 0.8 is considered pretty good. And, maybe if it's for a very, very large organ like the liver, you can have a little bit more leeway, but if it's if it's for something that would be maybe a little bit more high stakes, like something that is, measuring cancer lesions, measuring metastatic disease, and something that's going to be guiding treatment over time, you would want something more in the 0.9 plus range. I don't know of a specific dice score gold standard though, so that's a good question.
I appreciate your insight into that. I'm actually working on a project for like vascular detection and segmentation, and so it makes sense, yeah, that it'd be more high stakes and we need a higher dissimilar coefficient, which means we have a lot more work to do in training and validation. So, but thank you so much for that.
Oh, I see a hand raised from Ahmed Abdo.
Yeah, thanks for the great talk. I actually had two questions for you. So I think in some aspects, AI is like better than a radiologist, but there's some like hesitancy to embrace it. So I'm wondering like how can we like circumvent those scenarios? And then my second question is about data. And for someone who's interested in doing like radiology research or just like playing around with different data sets and trying these machine learning methods, where's a good place to get radiology data?
Yeah, so the first question regarding hesitancy or AI hesitancy is a very tricky one, and that's something that a lot of vendors really have to overcome when they're talking about their tools to potential clients. That some of the biggest concerns are going to be how easily is this going to be integrated into practice? How much can I trust the results? And is this going to be something that answers a problem? Like, is this something that is answering a problem that I have, or is this just going to be a neat toy to have in the background? So we have a very regimented, very methodical stepwise process that we take whenever we're evaluating a new AI application. It's something that fundamentally we have to be able to answer those three questions right off the bat. But yeah, more broadly, being able to we haven't really had like a killer app for AI quite yet. So we have some really, really cool applications in use here at UAB, like the intracranial hemorrhage and the pulmonary embolus tools. But even those, we study them, we've studied them post-deployment and have shown that, the pulmonary embolus tool works pretty well. And it's, it has made us faster in those areas, and it's picked up some findings and studies that we missed, which has been great because those patients have gotten appropriate care afterwards. But even so, the other two applications, really don't, they didn't really make us any faster, and they didn't make us any better. Like, we weren't missing anything that was really significant in those two areas. And those, that's one of the biggest AI applications, or most popular AI applications that's out there, are these pulmonary embolus and intracranial hemorrhage tools. And with those, we were able to show that it didn't really substantially make us any better. So I think partially it's just that we haven't had the killer app come through that is we've got to have that to make our practice better. And then in terms of finding data, I'll admit I come from a place of exceptional privilege that we have a lot of imaging data to work with, and we have a very robust human imaging lab at UAB that we're able to acquire and anonymize very large sets of data very easily. There are publicly available data sets and for chest radiographs and for head CT. I think the ChecksNet was the biggest one for chest, and I'm blanking on the CT head one. But there are a couple of good large publicly available data sets for those types of images. If you want to send me an email, I might be able to find those a little bit more easily. I'm gonna put my email in the chat, actually just for everyone anyway. in case there are any additional questions that we don't get answered here, while I'm live.
Awesome, thank you.
We had a question. So one thing that's very important is how do you prioritize data sets and who gets access? As you mentioned, the privacy aspect. Can you talk more a little bit about data governance and how you guys are approaching that in the radiology department or at UAB for all of our listeners that are not part of UAB?
Yeah, definitely. So, so data governance, patient privacy is exceptionally important. So we've had a very robust human imaging lab as part of our, as part of the radiology department for several years now. And so we're able to handle a lot of these processes in-house that we take images that are acquired within our own health system. And I mean, we do, I think, 800,000 exams a year of all different types. But we have a very, very large set of data that we're able to work with at any given time. So if we're working with a group that wants a specific set of images, like say that we want patients with a history of meningioma from who are of a certain age from a certain time that have received a certain treatment, then we would be able to query our our electronic health record and our PACS system where we store or where we have our medical images. We're able to acquire those accession numbers. We send those over to our human imaging lab, and they have an automatic process that de-identifies these images and makes them available for use for algorithm training. There are also imaging consortiums that you can be a part of that that have a de-identification portal that removes all identifying information from these exams and puts them in a multi-institutional pool. And so groups that are a member of this consortium are able to use this multi-institutional data set to be able to train their applications and get outside of their own limited single institution data. So it's that process is very complicated and requires legal review. It requires information, the integration with information security, and lots of signed documents and all of that good stuff. So it is a very, very intentional and very cautious process to ensure that there's no identifying information that gets out. And you have to be careful with a few specific types of radiology exams also, right? Because if I send out a head CT, we have the typical identifying information. We have patient name, date of birth, we have medical record number, the things that you think about. But we also have facial data that's included in these. So I could take sometimes, and there was a big article that was written on this a couple of years ago about kind of this oversight and privacy for some of the publicly available CT head images, that you could reconstruct facial data, and you were able to identify individuals who are part of this allegedly de-identified anonymized data set.
Thank you for that insight.
Hi, Dr. Perchik. I'm not Ahmed. I'm in the room with him, but I'm doing a project currently that involves machine learning from CT images. The question I had is from a concern that was brought up was that between CT machines or MRI machines at different hospitals, there is machine variability when it takes the images. So if you want to use those images for the training of a AI model or machine learning model, how would you go about standardizing those images?
Oh, that's a great question. The answer is you don't want to standardize those images. You want a wide variety in the types of the types of images that you're getting. So that's something that's going to make your algorithm more robust as you're or providing more variety in the types of images that you give the algorithm to train on. So that's, well, I'll give that the caveat. If this was something that you were wanting to develop, like to be deployed in the marketplace, you absolutely would want as much variability as possible. If this was more of a proof of concept, you might prefer to have, excuse me, you might, opt to have a more uniform set of images just to show that this is something that could be done in the future. But if this is going to be for a larger publication or for, certainly for deployment in for use commercially, you would want a wide variety in the types of data that you acquire, the types of scanners that you acquire, diversity in patient populations, diversity in image quality. And you would actually want to even introduce your own levels of, or you could even introduce your own levels of variability. Like you could add imaging filters, you could add grids to make them make the image quality lower to augment your data set. So the short answer would be if you're looking for a robust algorithm, embrace the diversity.
Thank you so much.
So Dr. Perchik, one thing I was wondering is, as far as testing out the efficacy of different AI models, I know there's a lot of hesitation behind doing any sort of randomized control trial because you have like the ethics concern of what if a patient gets bad care. And I know in the AI applications of cardiology, things like for ejection fraction, there are some people who've come up with some creative ways that they can still get that high level of evidence without putting any patients in harm's way. And I'm just wondering if you know of any creative solutions where you can do some robust testing on these things without the ethical concerns of poor care for real life test dummies.
Yeah, certainly. Yeah, the gold standard of like the double-blind multi-institution clinical trial is not as easy to perform with AI applications. But at least in radiology, we have a lot of capability of being able to use our head-to-head tests of a human versus AI versus the human plus AI. Is one of the very common ways that will show efficacy of an AI application. And that's not something that we necessarily have to have prospective data on. That can be something that we have a defined data set and we can say, all right, well, I'm going to read 100 CTs individually, and then I'm going to read 100 CTs with the assistance of an AI. And the AI is going to go through itself and interpret these 100 CTs. And we're going to see, what the performance level is between the three of us. And we're able to do very well with those with proving efficacy. And I mean, that's really kind of where the marketplace is right now as well, because these are all going to be radiologist assisting tools. These are not, tools that are going to be functioning autonomously. When we do get to that point, if there's ones that are more autonomous, then that could be something that would require, more or something more equivalent to a randomized trial.
Awesome, thank you.
And I have a hand up from Nicholas Beckman.
Yeah, thank you. This has to do with just kind of future implementation of AI. I think like or at least my understanding, it makes 100% sense to me that one of the biggest barriers to progression of AI is whether or not it's going to be paid for, whether there's going to be a model for reimbursement for implementation of AI. And, even if AI improves outcomes, there are so many other aspects of imaging that improve outcomes for which we don't receive additional reimbursement. For example, imaging on a higher field strength magnet, a 3T versus, 1.5 or even lower field strength magnet, having subspecialty interpretation of exams, addition of advanced imaging techniques, all of which we use at CIS facilities, but we don't receive reimbursement for them. If we don't receive reimbursement for these other, additions to imaging interpretation, how realistic is it to expect AI to be reimbursed in the future?
Yeah, no, I think you've hit on a very important point for another issue for why AI hasn't been adopted more widely is that the return on investment is a lot softer of a return than if you had I'm bringing on new technology which is going to give me another billable procedure that we're able to do. Like that's the opportunities for that in AI are few and far between. You know, initially there was a specific reimbursement for the use of CAD in mammography. And then I believe one of the only other like CPT codes like reimbursable procedures in AI is maybe in ophthalmology, that there's an AI augmented ophthalmology screening or procedures done for diabetic retinopathy, and then maybe I think AI stroke imaging. But I mean, there are very few and far between. We talk about 333 plus, over 300 FDA cleared AI applications. I think there's probably less than 5 directly reimbursable codes. So when we think about return on investment, it's a much more qualitative thought on the return on investment. So is this something that's making the radiologist's life easier? Is it decreasing our turnaround time? So is it making me more efficient? So I'm able to read more exams in a day, generate more studies for the practice? Is it something that, on the other side, we didn't really talk about this, but there's applications that can decrease the amount of time it takes to perform an exam. So for an MRI, that may take 30 minutes, 45 minutes. If I have an AI application that can speed that up to 15 minutes, then maybe I could perform 4 exams in an hour on a scan or on every scanner instead of only being able to do 2. So it is a very important that's a very important step for practices to know how they're going to determine how effective an AI application is. So, it might not directly generate revenue, but maybe it's going to, make my radiologist happier, make them less burned out, and maybe I will have benefits in radiologist retention, or maybe it's going to increase the number of scans that can be done in a day, generate more revenue because we're able to scan more patients. Yes, and Nina Nariman, I have a hand up from you. And I hope I'm doing very well with everyone's the pronunciation of everyone's names. I am trying my best. Oh, that's perfectly okay. If you want to type your question in the chat, that's also fine. Okay. Oh, now that's a great question. And I'm going to, so Nina's question is to speak on the use of AI in pediatric imaging. And I'm going to play some inside baseball, and I'm going to reference a lecture that was done for our AI and radiology course just about 1 month ago. Sorry, this is very rude. Okay, here we go. So there are some specific challenges for AI in pediatric radiology, and that is partially related to pediatric radiology is typically very underrepresented in most data sets. Excuse me. And that is partially because there's just not as much imaging that's done on pediatric patients. There's a lot more concern about radiation. Oh, excuse me. So there's a lot more concern for radiation. There's not a lot, or less just like kind of general scanning of pediatric patients compared to adult patients. Thankfully, pediatric patients aren't the pediatric population is not as sick as the adult population is, so they don't have to go to the hospital quite as frequently. So, the applications in pediatric imaging are pretty limited. They're not nearly as realized as they are in adult imaging. And, out of 333, I think there's maybe 10 or so that are in pediatric imaging. And of those, I think only maybe 1 or 2 are directly related to pediatric imaging. But I'm putting a link to the YouTube or the recorded lecture from our course This was given by Andrew Smith, who's the chair at St. Jude Children's Hospital in Memphis, Tennessee. Excellent lecturer, expert in AI, good friend of ours, a former attending at UAB. We miss him dearly.
Awesome. Well, Dr. Perchik, thank you so much for offering your time with us. You not only provided us an overview of AI in radiology, but a lot of use cases and also a little bit about like the forward-thinking insight that our generation needs to bridge. And honestly, it's very rare for us to have conversations with people that are leading their respective field. And so we thank you so much. And we need more conversations and discussions like this. And so if you're here today, we highly recommend that you join our listserv. Yeah, I'm going to send all the links in the chat. But essentially, we highly recommend you join our listserv because we're going to be bringing in speakers from all over the world that are leading their field. Our next upcoming speaker is the Vice President of Healthcare Innovation at Duke and MGH, who's going to be talking about AI and robotic surgery. We're going to be posting all of our videos and past events also on our platforms, LinkedIn and YouTube. So if you or a colleague are interested in this, we highly recommend you join our community. But without that said, thank you very much, Dr. Perchik, for offering your time and value. We greatly appreciate it. And that's it from the AI Med Trailblazers.
Oh, it's great to be here. Thanks again for the opportunity.